All right, our own little fireside chat now. So I want to actually jump right into it because I thought this morning we had such a wonderful time hearing everything about the social and political determinants. The speaker is actually speaking to me. I wanted to start with the middle, Dr. Tice. And by the way, we are going to actually jump right into it. The bios for each person is written in. I want to actually jump right into questions about this just in the interest of time. So Dr. Tice, with your work as the Chief Health Equity Officer at GuideWell, I wanted to start by asking, how does your focus on data and analytics allow you to identify cultural barriers that may be influencing Black men's health specifically? As we just heard, Wisdom spoke so eloquently about her journey and the journey of so many of our brothers across the ecosystem.
Well, first I'd like to say thank you so much for the opportunity. This has been, you know, you go places and you think you're going to give something, but then you end up getting something. So thank you for the opportunity to sit in your midst today. And just for clarification, those of you who don't recognize what GuideWell is the parent company, the mutual holdings company under which our main arm, Florida Blue Insurance, sits. And you talk about data and analytics. You know, I've been with GuideWell almost 6 years now, and before that I was a health officer. And I can't tell you the narrative we worked, we built around the "we don't have that data" answer, right? We don't have that. We don't know that. We can't get that. We can't ask that, right? And so that wasn't exactly true. And so a lot of what we have done at GuideWell in the last 5 years or so has been to sort of break through that paradigm, accept what it is that we do have in terms of data. And when we can't get member or self-reported data, we impute it. When we can't get that, we co-locate all the publicly available data that we have. Like, we just figure it out. Like, you figure it out. Let's stop telling ourselves that we don't know things that we know, number one. Number two, we have to stop behaving as if we don't expect to see in our own data, speaking as a payer, the things that we see reported broadly on the national and state levels, right? We shouldn't be shocked that we identify disparity gaps within our member population because disparities are a thing. So once we get over that part of it, then we do what we are doing now, which is being really intentional about landing the data that is available to us from every source that we can land it from, and then putting the proper and appropriate governance around that, standardizing it, determining who has access to it. And then what I'm really excited about that we've begun to do, and I worked a long time to try to build relationships with my my analytics partners. They're a tough group. And at Florida Blue, the analytics folks are they're actuaries. So I mean, forgive me to anyone in the room who might wear that hat, but oh boy, right? Oh boy, like, I'm not going to put it in print. I'm not going to send it to you in a deck. I'm not going to corroborate it if you say it in a meeting. Like, it was rough. And the partnership we now have is one where we have come together to build a repeatable framework that defines our approach to analyzing our population for said disparity gaps, right? Which is a huge win. So we are intentional about getting it and gathering it. We are intentional about how we standardize it and aligning it to the standards that exist across the industry. We're not great at sharing it yet, but it's on my list. And then we are very intentional about how we apply that data to govern what we do, where we dedicate resources, how we launch programs, how we evaluate the impact of those programs.
Awesome. Luther, I don't want you to actually get any rest, so we're going to go right into one for you, actually. The title of this session is How We All Win Together, and I think that this conversation has been going on all day. I want to ask you, actually, you just had that brilliant conversation with Lindsay. We're all with Wisdom Powell. We're all in this together. How do you see your work representing this if you will.
So when I started this work, many moons ago, I'm not going to say the year, many moons ago, there was only one community that I was focused on, and that was the community that I could see, feel, and touch. Now, I am challenged with understanding both the offline community and the online community, and the interplay between them both. And that challenge, although it may seem very abstract, ask any school principal about their day-to-day existence trying to toggle between offline and online interactions with young people in their schools, and how disruption can happen at a moment's notice by some tweet or some text message that was sent by one student about or to another student. Well, that same interplay exists in community health. It could be one piece of misinformation, one piece of information about a system or a provider or et cetera that could disrupt hours or years worth of work that you may have spent trying to build trust with the community, trying to build trust as a provider, trying to build relationships that you can then leverage to the benefit of the entire community. And so I think that the we now has expanded to be a very nuanced and high-level understanding of people as they exist, not only as you walk in chance encounters by them in the community, but also learning, collecting data, understanding how they operate and how they live their lives online, because that's just as valuable to their demographics as knowing their weight, their race, their level of education, et cetera. And absent of that full comprehensive understanding, you are not doing modern community or public health.
No, that's awesome, awesome. And Gabriel, this is where your work has really been visionary. You have deep roots in the South Florida communities. You represent the YMCA. And the Y has a particular approach that we talked about that I really want you to share with this audience, the way you guys address health equity. And I believe it's through the health navigation program that you have. Can you talk to us a little bit about that?
Of course. First of all, thank you, everyone. Can you hear me? Yes? Perfect. So I have my team here, and before I say a word, I want them to raise their hands. If you have any questions, you can just go and talk to them. I couldn't do anything. They are actually the ones that do the job. So it's so funny that you mentioned a minute ago that we come here thinking, oh, we're going to share something, and I hear so much, because even today, I've learned so many things, and kind of confirmed my thought process, which I always think to approach health equity is like a mosaic. Everyone has their role, everyone has their piece, but until we put it together, we're not going to see what that is. We may have the most beautiful mosaic, but if the pieces are apart, we're not going to be able to appreciate it. And times like today, given this space to have these conversations and be able to talk about all of this together, is when we can see that picture. And I hope that everyone think about the pieces of the puzzle they cannot saw today that have not seen before, and how they can collaborate to make the bigger picture. One puzzle of it is how the YMCA has been able to really address health equity. And we think that to be able to do that, we have to hold the hands of the people that need to be served, because there is so many things that happen in their lives that sometimes they just can't see the light. In that manner, we have the program that is person-centered, community-based. So we really literally go to where they are. They may be at home. We might meet them at the parking lot of Walmart or the CVS, because they may not feel safe in the communities they live in, and they want to still get the support. So we have been able to really also identify people in the community, and we train them as community health workers, a game changer. So they are people that then go and serve their friends, family, neighbors. They look like them, have the same background, and have gone through the same or are even going through the same challenges. And that is the best way possible. The program has 3 tiers depending on the level of need, and then the health workers will do the assessment, allocate them or assign them to a tier, and there is a whole array of services. But that's been a game changer for how do we address health equity, because when you get to them and you address their needs at their level, you ask them for what is it that they need and know what you think they need, and then address those things first. Until then, you can get to what you think they may need or you may be able to support with. And that's how you really gain that trust and able to really change the game.
No, that is amazing. When you describe it to me, yeah, please. When you describe it, I apologize. I'm not sure what I did there. But when you described it to me, I was truly impressed with our proximity. I did not realize, as close as I am, Jackson North, as I did not realize how much work was being done. And that's one of the things that I also learned as a learner here at this summit, is how much we're doing separately and not being aware that a lot of us are actually engaged in this battle of figuring out how to bridge those gaps in health equity. And so coming back to you, Dr. Tice, as a physician, obviously, I've fought with insurers for my entire career. However, what role do insurers have in helping to improve health equity? I know that you've been a part of this work. How are you tackling this problem from your vantage point?
And it's certainly a difficult one, and I never imagined myself, I too am a National Health Service Corps scholar. I never imagined myself not being in practice, not being in the area of direct patient care. It was something that was so extraordinarily meaningful and valuable for me. It became very difficult to, when I came to the realization that I couldn't have the impact I thought I needed to have in the 20 minutes I had with patients in the exam room. Now, there are a few things. I think one of the major challenges is that the expectation of the member, the patient, is not that we, when we define ourselves as a health solutions company, that we step in and solve anything for them, right? Those folks who have a Florida Blue card in their wallet just want us to get the heck out of the way, right? And make sure that it works when it's supposed to work behind the scenes, seamlessly, without challenges, and without, hopefully, physicians going, I'd love to do this for you, but your insurance won't pay for it. And that happens, unfortunately, a lot more often than any of us would like. I think, in all honesty and transparency, we are learning how to be that. We've got more than 7 million covered lives in this state, and we have adopted a local market approach. So there's a team that focuses on the southern part of the state. When I was a health officer, one of the things that I heard was, if you've seen one Florida county, you've seen one Florida county, right? We are different. And we can't come to any conversation about health needs without recognizing the differences and nuances that exist in each community and each area of the state. And so those local teams have the responsibility of identifying, not just naming the needs of the community, not just building relationships with our members in each community, but also identifying partners in each area of the state that are doing it right. So it's not so much my job or our job to deploy the solution. It is our job to identify who's doing it well and step up to help fill the gaps. And we do that by, ensuring that we are aligning our philanthropic support properly, right? We used to sort of give to everything, and now we align to certain things because we want to have more collective and sustainable impact. The harder part is the payment changes that need to happen, and that's where I think most payers have been sort of slow to the game, right? And even if in our initial attempts at value-based care, we have missed the mark significantly because many of the folks that have led those charges have not come to that work informed about social and political determinants of health and what it means to be a physician in a community that has been chronically and historically under-resourced, right? And now we're focused on quality, but you didn't change the resources that are available to me, right? And I'm a family doc, and I don't want to ask the question without being able to offer you a solution. And there are so many communities where we've got clinicians who have practiced for years and years and years, and they have carried their offices, their patients, their community centers, their clinics on their backs. I was one of them. I was trying to figure it out. I was scheduling extra time with patients. I was working through lunch, right? And it is our job now as payers to step up to the plate and partner differently, not just on the community side, but on the provider and clinician side, to really determine how we connect the resources in order that we are not in the way. So the spotlight is on, so is the music getting ready to start? That's our role. That's what we need to be doing now. And it is not as easy as it sounds, right? We have constructed a number of barriers through our own contracting that we now have to walk back. I think that the most important thing, though, is the want to, right? There are a lot of folks who, were talking, and you knew good and well they didn't have the want to. So having the desire to have those sorts of impacts with the changes that are happening in terms of, the social determinants of health screening requirements and the shift, with accreditation and quality and that sort of thing, like we got to get in there. That door's open. And now it's the responsibility of folks in roles like mine to walk through that door and see what those agreements need to look like in order for us to really achieve health equity, not just talk about it.
Brilliant, brilliant. Gabriel, I'm come back to you for a second here. What role do partnerships, you're the why, you depend on this. So what role do partnerships with nonprofit organizations, healthcare systems like mine, play in your work in the health equity? You are literally on the front line of providing this and trying to bridge that gap. Talk to us about that.
I'm so glad that you're asking me the question right after the payers' input. Really, when we look at partnerships, it's the only way to do things. I am sure that there are people here are representing many community-based organizations. And I think that without community-based organizations, we'll have a real health crisis, because we have learned to lean on community-based organizations for so long, and now we take them for granted. If there were not organizations providing food, doing case management, providing services to different type of populations, especially vulnerable populations, we will have a lot more health-related issues. So you can only do things through partnership. But I always think that we have done so much really sick care in this country. We now, finally, for the last few years, are talking about prevention. Finally, are talking about putting the names and the labels on the things that we now know, political determinants of health, social determinants of health. Sometimes they are overutilized now, those terms, because everyone speaks of it, and it's nothing, we have known that, no, but how do we solve it? And you're not going to solve it in any community unless you sit at the table. Same concept with the puzzle. We may have all these pieces, but if we don't sit together and put it together and have a common language and a conversation, we're not going to get there. And it is important not only the role that everyone will play, but pay is then the other key. So community-based organizations struggled. We are the why. We're a non-for-profit like many others, and we struggle to get the funding, to get the resources, to get hospital systems, insurance companies, foundations to provide the financial resources so that the work can be done. But in my head, it works perfectly well. right? There are health systems, health insurance companies, maybe cities where they actually start looking at the services of community-based organizations, just like they will look at the radiology services, the lab services. Those are contracts. Those are absolutely services that when you're in the hospital, they put an office of physical therapy in there, and they contract with the radiology, and they contract with the pharmacy. And why not contracting with community-based organizations that are the ones that actually hold their hands or the clients when they leave the hospital? And the fact that we're here talking to you about all these things is because the need is there. There are super utilizers, there are people that are struggling, there are people that they don't know what to do next. Hospital systems and healthcare providers are not everywhere. Sometimes people have to get care and they're like really far from where they need to get the care, and that's just a barrier right there. So, and then who comes to solve the issue or try to solve it sometimes? Community-based organizations. So I really think that, when we talk about partnership, it's critical. I think that when we're all seated at the table and having these conversations and everyone bringing their strength, I heard this morning, or not this morning, a while ago, how do we talk about an asset-based conversation? So what is it that everyone can bring that really is different from others so that we all together can actually make a difference?
No, that's brilliant. Thank you. And I think that even as you talked about the mosaic earlier, sitting in this room, you are speaking to people who are actually my own partner, Barbara Fonte. We talked about that, about how this is so needed and how she's leading the charge in our health system, because that's one of the things. We're all doing this in separate spots, and we thank the Health Foundation because bringing us together in this room and having these discussions allows us to see that we're actually attacking the same problem from the different vantage points, and we can get there together. Luther, back to you. I'll put your innovation hat on here. How does your work with new innovation interrupt implicit bias and build health equity? I know this is right up your alley.
So there's a number of things, and they kind of touch on a little of everything that's been said so far. My initial work was in the academic sector. For those of you who don't know, we put a program together to require medical students to perform home visits in low-income, medically underserved households right here in Miami through a program called Neighborhood Help. And a lot of what you were saying around putting forward the value proposition to groups for seeing value and having medical students and our community health workers do these visits and seeing a way for that to be compensated by external groups was a lot of the challenge, right? Even though we were funding a decent amount of it through hard dollars, through the training of the students, it still had external value. But one thing that did resonate with me was that I took from it was this critique about it being scalable. And so it took me into the realm of really understanding the business of medicine and the fact that, yes, when you see one community, you've seen one community. However, to operate at scale, there have to be some kind of shared innovations. And in the process of creating those innovations, we have a unique opportunity to embed or right the wrongs of the systems that we originally designed. AI is all the rage right now, and everyone is seeking an opportunity to use AI to replace instead of complement a lot of the work that we are talking about here right now. But it could be damaging if we take the same models of bias and discrimination and segregation and train the AI model to mimic that or mirror that. So one of the things in my current role as a partner with the WellUp, one of the things we have done is we have integrated or translated the 17 plus years of the work that I initially was doing here in South Florida and now do in Las Vegas around these home visits, around working with partners, and putting it into this app, because one of the things that I would probably challenge everyone in this room who is doing remarkable work is, if you don't translate your expertise to the digital format, someone else will do it for you. And if you allow that to happen, then you are just as culpable for what you find as the outcome product. And so I saw it as my obligation to translate what we did around seeing the household as the smallest unit of care instead of the patient. I saw the need to create teaming that enabled professionals and non-professionals, lay and not lay workers, to all communicate together. I saw the need for us to find a way to be a painkiller instead of a vitamin to the health systems, so that they don't just say, oh, that's cute, but I don't really see how it fits with our compensation model. That is incumbent upon us. And so we, if I'm being very honest, in our early days of doing this, we were more vitamin than we were a painkiller. And what we learned from that was that we were trying to be a solution for all. And so what we did is that we realized that our strength was to find that thing that we would be most impactful for, and we found it to be behavioral health. And so very happy that we now have gotten investment from a behavioral health company that is now partnered with us and is now going to use us within their operation. That, to me, is now taking what you asked me about to the next level, because if I can create a tool that has those things, that is protecting against those things, and I can then get it to scale to a larger commercial market, then I now provide that almost embedded opportunity for health systems. So that, because one thing I've come to learn is that it's very difficult to change culture one person at a time. But oh my God, doctors will do whatever is in that electronic health record if you put it in front of them. And so if we can get it embedded in that electronic health record, I don't care what it says, somehow, some way, if it builds right, it's going to work. And so no slight on you, Dr. Price, you're not one of those. But that's the long answer to a very complex issue. But yes.
No, that's awesome. That's awesome. All right. In wrapping up, I want to actually pose a question to all three, and starting with you, Dr. Tice. And this 2024 iteration of the Black Health Summit is building awareness around the issues surrounding Black men's health and the challenges of personal choice, when in reality, health is created largely by social and political and physical environments. So can you comment on the intersection of your respective approaches and current work, for that matter, to Black men and boys?
So I mentioned that we have a hyper-local approach, and I won't suggest that we've gotten that right early or often, but we are continuing to sort of focus on the ideal target. And what I mean by that is, it is very easy. It is very easy with a very well-resourced enterprise to, check the boxes in terms of we give this amount, we contribute here, we show up here, it's branded well, it looks nice. It is a very different thing to position yourselves in communities to hear from the trusted thought leaders in the communities, what is actually needed. It is a far different thing to hear from community-based organizations that have been doing the work, right? They showed up long before we showed up with our photo op, where the gaps are. One of my pet peeves, as a former public health officer where I had $5 to do everything, right, is to watch funders sort of show up with this money with all the labels and constraints and tags and restrictions on it, and never once do they ask the question, well, what do you need? Like, what's the problem you are continually having to solve? Well, the van always breaks down, and there's nothing in the funding that pays for repairs, gas, a driver, a this or that, the other thing. We're not asking the right questions. And so, I know, right? Like, it is crazy. You know, the state of disrepair of a lot of the things that are central to the solutions in the various communities is atrocious. And I think we do our community members a disservice by continuing to communicate to them that they should trust this rickety bus with the rust holes in the floorboards, right? Like that equates to the type of health and solutions that we are transporting them to. That's nuts. And we have to stop that, right? We have to redirect how we fund things by really listening, right? At the end of the day, we often fall victim to this idea of giving to you how we want to give, as opposed to giving into your need, because it might mean we need to rewrite the grant. We need to restructure the deliverables. We need to reconsider the metrics or measures or KPIs that we use, and no one wants to do that because that takes time, right? And so that's the shift that we're making, and so if I can structure an approach that ensures that I'm going to hear from who's in the room, and that the proper due diligence has been done to ensure that the right folks are in the room, then I don't have to necessarily worry about the who, because what my job is to build the system that opens all the doors, so that whatever door you need to walk through, right, it leads to, it provides you access to the solution. And that is complicated. And in many cases, it is not the goal of those on the corporate side of these sorts of problems. Like, we want to do it how we want to do it. And so what we'll continue to do is change our approach. I have a toolkit that I use internally with all of my internal stakeholders. You're designing a strategy, an initiative, you're launching a new program, you have a new solution. Hold it up to the light and let's see how it measures up in terms of health equity. Have you considered this, that, the other thing? How are you doing the funding? How have you partnered? How many times do we lean out instead of leaning into historically black colleges or Hispanic serving institutions that could be our academic partners for things, and we don't even think about it, right? Like there are some simple things we can consider that will hardwire this, so that as you who know what your communities need work, and you get black men in the room, at the table, engaged, listening, healing, understanding, that we're ready with the proper structure, funding, contracts, whatever, to support them.
Thank you. Gabriel.
That's a really, really good question. So I think there is many things that need to be considered. And obviously, I'm going to just talk about briefly on funding and really the end product, which is one you are actually serving. And thank you for sharing everything you share with that passion, because I feel like that many times. So funders come and say, hey, community, I think you need this. I'm going to give it to you, and then I'm going to pick you up. I'm going to help you. Oh, the funding is gone, and I drop you. The other one comes and said, oh, I think I know what you need. Let me just pick you up. I think I'm going to help you. Oh, the funding is gone. Drop you. And the seventh time they go like, stop. Do not. And we go like, oh my God, look at the distrust of the community. And we have caused that. We did that, and with a good intention. But we were missing the portion where we were asking. Again, one of the things that the team is brilliant at doing is when they come to meet somebody, and we can see the person may be coming to us because diabetes is off the charts and they're having all the complications. You will think that the first thing you're going to say is like, let's control the diabetes. The team is actually asking, what is it that you need? And they may say, well, I don't have food, I don't have childcare, I lost my job, I live with my son and he is sick, and my diabetes is out of control. They create an action plan that goes in that order. And maybe when those things are solved, then they get to control the diabetes. But that is not the first thing you are going to say, and that is listening. And if we look into that, or if we see that and make it even bigger, then we start talking to who are the organizations, the community-based, organizations, the community leaders, the people that everyone knows in the community that don't have to be necessarily connected to a non-for-profit or anything like that, but they know the community, they're willing to tell you. So why are they not at the table when you are trying to come in? I have had the pleasure to be at some tables sometimes with funders that say, hey, we want to come to the community. And my first question is like, are you going to stay here for 20 years? They go like, what? Because that thought process, I'm going to give you a year of funding and then you're going to be self-sustained, is not even current. So and we're like, why? I said, these problems that we are chasing right now have been created for 60 years, 70 years. We're not going to solve them unless we create strategies that are equally lasting. And until we all get together and say, we're going to commit together for the long term, we're only going to go back and forth on some successes in some areas. We're not going to be able to move everything forward. So the last thing I will add is, we were talking about the speaker, Dr. Cheryl was saying, hey, the women brings the men to care, right? And I think most of the community health workers sometimes happen to be women. And I think that they are the ones that are going to bring them to care. I think there are the neighbors that come back and they respect that figure and knows also the barbers and knows where they hang and knows the corner stores. And then they are the one that are having those conversations and saying, hey, this is what it needs to happen. Let me tell you why. And usually, and you all know this. So maybe the time number 10, they have spoken with them when the change happens. If you quit at 9, there will be no change.
Thank you so much.
Thank you, team. Thank Mom.
So, Luther, we have officially run out of time, so you have exactly 15 seconds to answer that complicated question. Go.
That's easy. I think the greatest thing I can do in that space is present myself fully. As a black man, when I got into this work, there were few to no black men in the space that I am, in the chair I sit in. And so I have had the blessing and the fortune to work alongside some of the best of the best, and I don't keep it to myself. Any person, especially in a field where there's so few black men working in it, can come to me at any time and ask me anything, and I go out of my way to ask them too, because the reality is that you don't want the legacy of your work to die with you. You would hope that you bring along a number of individuals who will take your place and will have that same commitment and that same passion. And so I don't take lightly the fact that, the chairs that I sit in, the work that I do should be emblematic and should embed in it my full existence. And part of that full existence is me being a black man.
That was 15 Jamaican seconds.
I got a piece of that,
Yes. Yes. So I want to thank our panel. This was really inspiring for me, learning that political determinants, they are the determinants, and continuing with this. Thank you so much. Round of applause for our panel, please.